Welcome to the Deep Dive, Future Medical Minds. We know first year can feel a bit like trying to drink from a fire hose.
Totally.
Especially when you hit the dense stuff like anatomy and neurology, all those upper limb nerve injuries. They can seem, well, pretty overwhelming at first.
Yeah, definitely.
So consider this your, let's say, high-yield shortcut, a focused deep dive we've designed to make this complex, really crucial knowledge not just understandable, but hopefully unforgettable.
That's exactly our mission today. We want to arm you with a clear, memorable framework for understanding, retaining, and quickly recalling the major nerves of the upper limb.
The big three, right, radial, median, ulnar.
Exactly. And critically, how injuries at different points along their paths dramatically affect function. Think of this as helping you build your own internal wiring diagram of the arm. It's really a foundational skill.
Right. And this isn't just theory for an exam, is it? It's about building that intuitive mental map, the kind that's going to serve you really well in, well, every future patient encounter.
Absolutely.
So you can quickly visualize where an injury might be just based on the symptoms you're seeing. So
Yes.
yeah, let's plug in and connect those dots.
Sounds good.
All right, before we start mapping out the individual nerves, let's maybe zoom out a bit. What are the common culprits, like the big picture ways these critical supply lines actually get damaged? I'm guessing trauma is a big one.
Yeah, trauma's huge. That's a perfect starting point, actually, because the cause often gives you that first clue. Broadly speaking, we're looking at a few main categories.
Okay.
And yeah, the most common is trauma. This can be blunt trauma. Think fractures, where maybe broken bone fragment snags or presses on a nerve.
Like a humerus fracture.
Exactly. A humerus fracture hitting the radial nerve is a classic.
Okay.
Or dislocations, stretching the nerve.
Yeah.
There's penetrating trauma.
Bullet wounds, glass.
Yep, bullet, glass, knife wounds. Those often cause clean cuts, transections, and something maybe less obvious is shoulder dystocia.
During birth.
During a vaginal delivery, yeah. It can put this immense stretch on the brachial plexus, causing nerve damage in the newborn. And, sometimes it's simpler, like sustained pressure.
You mean like falling asleep weirdly?
Precisely. Falling asleep with your arm over the back of a chair, that can cause a temporary radial nerve palsy. It's often called Saturday night palsy. You'll definitely see that one.
Wow. So anything from a fall to a tricky birth or even just deep sleep, that really covers a lot.
It really does. Another big category, maybe one that'll surprise you, is iatrogenic injury.
Iatrogenic, meaning doctor-induced.
Exactly. Doctor-induced or treatment-related. So we're talking about injuries that happen inadvertently during surgery, maybe, or as complication of other treatments.
Oh, wow.
Yeah, there was a case report, for instance, of an incidental median nerve injury from a high-speed drill during surgery. It's rare, sure, but it's a real possibility.
That's definitely a stark reminder of the precision needed.
It is. And very rarely, things like cancers can directly involve or compress nerves too, causing similar problems. But really, for acute stuff, trauma and iatrogenic causes are what you'll mostly see.
Okay. What's really fascinating here is that regardless of the cause, there seems to be this fundamental rule, right? A golden rule that guides how we assess these injuries.
Absolutely. This is probably the most important concept to get down. The golden rule is this. When a nerve is damaged,
Yeah.
anything supplied proximally so, closer to the body, closer to where the nerve starts, that part will keep its normal innervation, normal function.
Okay. Makes sense.
But anything supplied distal, further away past the injury site, that loses its innervation. And so it loses function.
Ah, like a break in an electrical wire.
Exactly. That's the perfect analogy. Everything before the break still works, but anything after it just goes dark.
Yeah.
This principle, it's going to be your compass as we go through specific nerves. Love that analogy. Okay, and speaking of quick assessments, the power grip. That often comes up as a first clinical clue, right? How does that simple action give us a quick look at all three major nerves?
The power grip is such a great example of nerve cooperation.
Mm-hmm.
To get a strong power grip, you need a few things happening at once. First, your wrist needs to be extended,
Right.
and that crucial function. Heavily relying on the radial nerve. If you can't extend your wrist, your grip strength just tanks.
Okay.
Second, you need flexion of all your fingers. Now, the medial two fingers, your pinky and ring finger, they're mainly controlled by the ulnar nerve.
Got it.
And the lateral two, your index and middle finger plus the thumb's key movements, that's the median nerve doing the work.
Yeah.
So if someone can't make a strong power grip, you know right away there's likely an issue with one or maybe even all three. of those nerves.
And I've definitely heard about wrist drop being a classic sign of radial nerve injury. What's actually happening there?
Yeah, wrist drop is such a hallmark. It happens because, well, the radial nerve controls the muscles that extend the wrist. The extensors, right?
Exactly. So when that nerve's damaged, you lose the resting tone of those extensors. And the wrist just falls into flexion because the flexor muscles are now unopposed. It's a really clear visual sign.
Okay. So to navigate all this complex wiring, especially that brachial plexus, we probably need some handy anchors, right? What are your go-to mnemonics for the plexus itself and maybe for the reflex spinal
Oh,
levels?
mnemonics are lifesavers here, definitely. For the brachial plexus structure, roots, trunks, divisions, cords, branches. The classic is reach to drink cold beer.
Huh. Okay, I can remember that.
Simple, right?
Yeah.
And for the main branches coming off the cords, musculocutaneous, axillary, median, radial, ulnar. Try. Most alcoholics must really urinate. Kind of silly, but it helps lock in that sequence.
Those are great for mapping the nerves. And what about for quickly checking spinal levels? Those reflex checks are so key for a rapid neuro exam.
Oh, absolutely essential. For reflexes and their nerve roots, these are gold.
S1, S2, think buckle my shoe.
S1, S2, buckle my shoe. Got it.
Patellar reflex, L3, L4, kick the door.
L3, L4, kick the door, okay?
Biceps or brachioradialis reflex. C5, C6, pick up sticks.
C5, C6, pick up sticks. Nice.
Triceps reflex. C7, C8, lay them straight.
C7, C8, lay them straight.
Cremasteric reflex. L1, L2, testicles move.
L1, L2, okay.
And finally, the anal wink reflex, and S3, S4, winks galore.
S3, S4, winks galore, perfect.
These quick checks, they give you immediate insight into whether specific spinal segments are intact. Really useful.
Okay, great toolkit. Let's move on to our first big player then, the radial nerve. The extensor master, you called it.
That's the one. It comes off the posterior cord of the brachial plexus, then it does this winding journey through the radial groove of the humerus.
It's spiral groove, right?
Exactly, the spiral groove. It's a long path, and eventually it splits into a superficial sensory branch and a deep motor branch. The deep one continues as the posterior interosseous nerve. Understanding that path is really key to figuring out the different injury patterns.
Okay, let's put that golden rule to the test.
Mhm.
Imagine a patient comes in, maybe they use crutches incorrectly, too high, digging into the armpit, a high radial nerve injury there. What deficits, like the whole list, would you expect? Maybe take a second to think about it, listener.
Okay, so with an armpit injury, because it's so high up, so proximal, you'd expect to see a loss of basically all radial nerve functions.
Everything downstream.
Everything downstream. So loss of elbow extension, the triceps would be out, loss of wrist extension, there's your wrist drop, supination would be reduced, power grip would be lost or severely weakened, and you lose extension of the thumb and all the digits.
Wow.
And on the sensory side, you definitely expect loss of sensation to that little patch, the first dorsal web space, between the thumb and index finger. Other parts of the back of the hand might have some feeling due to overlap, but that web space is pretty uniquely radial.
Okay, that's a significant loss of function. Now, what if the injury is further down, let's say mid-humerus, that spiral groove fracture you mentioned? How does that presentation differ from the armpit injury?
See, this is where a golden rule really helps clarify things. With a mid-humerus injury, in that spiral groove, the triceps muscle, the one for elbow extension, its nerve supply often branches off the radial nerve before or proximal to the spiral groove.
Oh, okay.
So elbow extension would typically be normal in this case, but everything supplied distal to that fracture point, still affected. So you'd still see the wrist extension loss, the wrist drop, supination, power grip, extension of the thumb and digits all still lost, just like the armpit injury.
But elbow extension is spared.
Elbow extension is spared, and the sensory loss to the first dorsal web space, that would also still be there. It's a really common way for radial nerve injuries to present.
Got it. So the key difference for mid-humerus is spared elbow extension.
Yeah.
Because the triceps branches off higher. That's critical. Now let's follow the nerve even further down. Imagine a patient has a superficial cut, a laceration, on the lateral forearm, just distal to the elbow. If the radial nerve is hit there, what changes?
Okay, if it's only the superficial radial nerve branch damage there, well, that branch is purely sensory.
So no motor loss.
Exactly. All the motor functions, elbow extension, wrist extension, supination, power grip, finger and thumb extension, they'd all be normal. The only deficit you'd expect is that loss of sensation to the first dorsal web space. Motor function saved.
Okay, but what if that cut was deep, affecting the deep radial nerve, still distal to the elbow? How would the picture shift then?
Right. The deep laceration hitting the deep branch, which is mostly motor, that presents differently. Elbow extension would still be normal because the triceps is fine, way up high, and sensation to the first dorsal web space would also be normal because the superficial sensory branch wasn't hit.
Yeah.
But you would see reduced wrist extension, maybe not total loss, but reduced supination, reduced power grip, and a definite loss of extension of the thumb and digits because that deep branch, it supplies a lot of those extensor muscles down in the forearm.
Makes sense. Okay, one final radial nerve scenario.
Yeah.
An injury specifically to the posterior interosseous nerve branch, maybe in the mid-forearm. What's left and what's lost here?
So, posterior interosseous nerve, mid-forearm, quite distal now. Many functions are actually okay. Elbow extension, wrist extension, supination, and that first dorsal web space sensation, all typically intact.
So what is affected?
The key deficits here are a reduced power grip, and specifically the loss of extension of the thumb and the digits. That nerve branch really focuses on those fine motor extensions in the hand.
Okay, that radial nerve breakdown by location is super helpful. Let's switch gears. The median nerve, or precision gripper.
That's the one. It actually forms from bits of both the lateral and medial cords of the brachial plexus, which is kind of interesting. Its path takes it down the arm, and yeah, it's critical for innervating a deep layer in the forearm and ultimately controlling a lot of our fine motor skills, especially things involving the thumb and the first couple fingers.
All right. So sticking with our pattern, if there's a high lesion of the median nerve, a proximal injury, way up in the arm, what functional problems are we looking for? Especially if we ask the patient to, do something specific.
Okay, a high median nerve lesion. You'd expect a pretty comprehensive loss of its functions. Pronation, turning the palm down, would be lost. Wrist flexion would be significantly weakened. It wouldn't be totally gone because the ulnar nerve helps a bit with wrist flexion, but mostly gone.
Okay.
You'd see a loss of flexion at the DIP joints, those end joints of the fingers, and a really noticeable loss of thumb opposition, that ability to touch your thumb tip to your pinky tip, that's going to be out because the opponent's pollicis muscle is median innervated.
And sensory.
Sensory loss, yeah. You'd expect loss on the palm side, typically the thumb, index, middle, and half of the ring finger. Loss of sensation on the tip of the ventral index finger is a really key indicator.
Gotcha. Now, what about an injury just to the anterior interosseous nerve? That's a branch just distal to the elbow, right? How does that change the picture from the high lesion?
Another great chance to apply that golden rule. The anterior interosseous nerve, or AIN, it's purely a motor branch.
Yeah.
So if you injure just the AIN, pronation would be reduced, and that ability to flex the DIP joints of the index and maybe middle finger would be lost. But because the injury is more distal and misses the main trunk higher up, wrist flexion, thumb opposition, and sensation to the ventral index finger, all of that would remain normal. It's a much more isolated motor deficit.
Okay, that makes sense. Now, the one everyone hears about, carpal tunnel syndrome. Which median nerve functions are hit in this super common condition?
Right, carpal tunnel, it's all about median nerve compression right there at the wrist. So the deficits are pretty specific to that location. Pronation, normal. Wrist flexion, normal. DIP joint flexion, normal.
So what is affected?
The hallmarks are the loss of thumb opposition, making it hard to bring the thumb across the palm, and that characteristic sensory loss or tingling in the thumb, index, middle, and the radial half of the ring finger on the palm side. Night symptoms are really common, too.
Okay. And one more specific one, the median recurrent nerve. That's the little branch just for the ulnar muscles, right? What happens if just that gets injured?
Exactly. The recurrent branch is very focused. It primarily hits the thenar muscles, those muscles at the base of your thumb, and maybe the first two lumbricals. So if only that nerve is injured, maybe by a cut near the base of the thumb.
Yeah.
Pronation, wrist flexion, DIP flexion, even sensation to the index finger, all totally normal. The only critical deficit would be the loss of thumb opposition because you've knocked out those specific thumb muscles. Very precise deficit.
Wow, okay. So we're really seeing how pinpointing the location is everything. Are there specific clinical tests or maybe classic presentations that scream median nerve issue?
Oh, definitely. A key test is the positive bottle test. You ask the patient to wrap their hand around a bottle or a can. If the median nerve's out, especially affecting the thenar muscles, they often can't fully abduct their thumb to get a good grip around it. Their thumb stays kind of flat against the bottle.
Ah, I can picture that.
You also learn to Nulse test, where you tap over the nerve at the wrist. If it causes tingling or pins and needles down into the fingers, that suggests compression, like in carpal tunnel. And just looking at the hand at rest, a significant distal median nerve injury can lead to an ape-hand appearance.
Ape-hand.
Yeah, it's because the thenar muscles waste away, so the normal bulge at the base of the thumb flattens out, and the thumb tends to fall back in line with the other fingers, kind of like an ape's hand. It loses that opposable look.
Got it. Ape-hand, bottle test, Tinnels.
Mm.
Good anchors. All right, let's tackle our final major nerve, the ulnar nerve, the medial powerhouse.
That's it. Comes off the medial cord of the brachial plexus, takes its own distinct path down the medial side of the arm, famously going behind the medial epicondyle at the elbow, the funny bone.
Ah, yes, the funny bone.
Exactly. It's unique because it only supplies 1.5 muscles in the forearm, the flexor carpi ulnaris, which flexes and adducts the wrist, and the medial half of the flexor digitorum profundus, which flexes the end joints of the ring and pinky fingers. But its main job, it supplies most of the small intrinsic muscles within the hand itself.
Including those tricky lumbricals and interosses.
Precisely. Remember, lumbricals do that unique thing. Flex the MCP joints, the main knuckles, while extending the PIP and DIP joints, the finger joints. The ulnar nerve gets the lumbricals for the ring and pinky. And the interosseous muscles, also mostly ulnar innervated, they help with spreading the fingers, DAB's dorsal abduct, and bringing them together, palmar adduct. And they also crucially help the lumbricals extend the PIP-DIP joints by pulling on the extensor tendons. Complex little setup.
Definitely complex. Okay, so let's look at an ulnar nerve injury at the elbow. What deficits should we expect then?
An ulnar nerve lesion right at the elbow, maybe from hitting that funny bone hard or entrapment there, is pretty significant. You'd expect radial deviation of the wrist on attempting flexion. Why? Because the ulnar-sided wrist flexor, flexor carpi ulnaris, is knocked out, leaving the radial-sided flexors unopposed.
So the wrist pulls towards the thumb side.
Exactly. Wrist flexion overall would be weakened. Critically, you'd lose the function of the dorsal and palmar interossae, no more dabby or pads in the lumbricals to the ring and pinky fingers. The hypothenar muscles, those muscles in the base of the pinky, also gone, and sensory loss. You'd lose sensation on the medial side of the hand, basically the whole pinky and the medial half of the ring finger, both palm and backside usually. This kind of lesion is famous for causing a claw hand deformity at rest.
Okay, the claw hand. Now here's a really tricky question you hear about with the ulnar nerve. Which injury is actually worse for the claw appearance, one up at the elbow or one down at the wrist? It seems backward.
It does seem backward. It's a fantastic question, and it leads us straight to the famous ulnar paradox. And the paradox says, the closer to the paw, the worse the claw.
Closer to the paw, worse the claw. Okay, explain.
So with an ulnar nerve lesion down at the wrist, say from a cut or compression in Guillaume's canal, the wrist deviation wouldn't happen, and wrist flexion strength would be normal, because the flexor carpi ulnaris muscle up in the forearm is still working fine.
Right. Innervation is proximal to the wrist injury.
Exactly. But you'd still lose the dabus pads, the medial two lumbricals, and the hypothenar muscles, because they're innervated distal to the wrist. Now here's a twist. Sensation to the back of the medial hand might actually be normal.
Why is that?
Because the dorsal sensory branch of the ulnar nerve, the one supplying the back of the hand, often branches off above the wrist. So a wrist-level injury might miss it. Sensation on the palm side would still be affected, though.
Okay, but why is the claw worse if the injury is at the wrist? That still seems paradoxical.
Right. Here's the paradox payoff. The clawing, that's the hyperextension at the MCT joints, and flexion at the PIP-DIP joints of the ring and pinky, it looks worse with a wrist lesion. Why? Because the long flexor tendons to those fingers, the FDS and FDP.
Flexor digitorum superficialis and profundus.
Profundus, exactly. Those are still working perfectly fine because their muscle bellies are innervated way up in the forearm, partly by median, partly by an proximal to the wrist. Normally, the lumbricals and interossae balance out the pull of these strong flexors, but with a wrist lesion, you lose the lumbricals and interossae, so the FDS and FDP are unopposed.
Ah, so they just pull those fingers into a tighter claw.
Precisely. They yank the PIP and DIP joints into more flexion, and the MCPs get hyperextended because the lumbricals aren't there to flex them. With a high lesion at the elbow, the FDP to the ring and pinky is also weakened, so it can't pull the fingers into such an extreme claw. More muscles are out, but the deformity looks less severe. It's a classic paradox.
Wow. Okay, that explanation really clarifies the closer to the paw, worse the claw idea.
Yeah.
It's about the unopposed flexors. Brilliant. Any key clinical tests specifically for the ulnar nerve?
Yes, a really important one is Froment's sign. This tests the adductor pollicis muscle, which brings your thumb towards your palm. It's ulnar innervated. You ask the patient to pinch a piece of paper firmly between their thumb and the side of their index finger, and you try to pull it away.
Okay.
If the adductor pollicis is weak due to an ulnar nerve problem, they'll compensate by strongly flexing the very end joint of their thumb, the IP joint. They're using their flexor pollicis longest muscle, which is median innervated, to cheat and hold on. That flexion of the thumb's IP joint is the positive Froment sign.
Got it. Flexing the thumb tip is the giveaway.
Mm.
Excellent. Okay, so wrapping this up, what does all this mean for you, our listener, as you start your clinical journey? We've covered a ton today.
We really have.
From the causes of nerve injury, the golden rule, to the specific signs of radial, median, and ulnar nerve damage at different spots. Radial often means wrist drop. Median can give you that ape-hand or precision grip problems, and ulnar leads to the claw hand and that ulnar paradox.
And what's truly, I think, insightful here is seeing how understanding these anatomical paths, these landmarks, really becomes your diagnostic GPS.
Yeah.
These roadmaps let you start pinpointing what's gone wrong and which nerve is involved just based on what the patient can and can't do. And please remember to partner your revision of this stuff with actually doing upper limb exams for your OSCEs or practicals.
Absolutely.
The hands-on application, seeing these deficits, feeling the muscles, that's what really solidifies the memory and makes it click.
Definitely. And maybe a final thought to carry with you as you continue learning. Think about how these intricate nerve pathways, they aren't just, bundles of fibers in an anatomy diagram. They're the very essence of human function, of independence. What new innovations, maybe in surgery or rehab, might help us better repair and restore function to these absolutely critical supply lines that let us interact with the world? Something to ponder.